the AI Dupont Hospital for Children. And our two speakers will explain how they advance pediatric medication teaching. But before I introduce our speakers, let me go over some housekeeping issues. And please pay attention to the CME credit. If you need any CME credit, we have a new method now, so you need to register. And we are going to keep this slide right now for a few minutes. So don't miss our May 2nd Tech Talk with our own Dr. Zugui Zhang from the Value Institute, who will be speaking on mediation analysis and its application in medicine. So the Tech Talks are always in the Value Institute at the 8th floor, and that will be a really interesting statistical presentation. Also, please note that our May 10th ID series, we will have a special guest also, Dr. Neera Goyal, also from Nemours, speaking on primary care of infants with in utero opioid exposure. So that will be also a really great presentation on May 10th. So as usual, please register in advance to help us prepare. And the full schedule is posted on our website, DE-CTR.org. So I'm really excited to introduce our speakers. I will start with Dr. Elora Hilmas, who is currently the pharmacy clinical coordinator at the Dupont Hospital for Children. She received her PharmD from the University of Maryland and completed her residency at the Johns Hopkins Hospital. She currently manages a PGY1 program and as well as a student internship program and all clinical pharmacy student experiences. She practices as a transplant pharmacist and has also been instrumental in developing and implementing a system for nephrotoxic medication monitoring in children. In 2017, she became the site principal investigator for a Cardinal Health grant focused on improving pharmacist involvement in discharge education. And in 2018, she became the pharmacist lead for implementation of patient-friendly medication discharge instructions. She also has multiple publications and awards. So thank you very much. And then Dr. Michael Dejos has been the medication safety officer at the Alfred Dupont Hospital for Children since 2015. He received his Doctor of Pharmacy degree from the Philadelphia College of Pharmacy, and after receiving his degree, completed a pharmacy residency in Penn State and St. Joseph Medical Center, and later completed a medication use safety fellowship at St. Jude's Children's Research Hospital. In 2016, he was awarded the Cardinal Health grant focused on improving pharmacist involvement in discharge education and has had multiple awards and honors, the last one as Pharmacist of the Year by the Delaware Society of Health System Pharmacists. So thank you very much and welcome.
Thank you very much for that kind introduction. As Claudine had mentioned, my name is Mike Dejos. I serve as Med Safety Officer at Nemours. And we really are so excited to share with you for the next 45 minutes or so the work that we're doing at Nemours Children's Health System, primarily the Alfred I. Dupont Hospital for Children, in advancing pediatric medication discharge teaching. We want to first begin that we do have a financial disclosure statement, in that Elora Hilmas, my co-presenter, is a paid consultant for Medication Action Plan. And although we'll discuss Med Action Plan, we will not go into any details about selling it to you, of course, but rather share with you all the unique attributes, the things needed to really launch a program as a tool and resource. Before this presentation's over, our hope is that you all will be able to list pediatric risk factors as associated with medication errors and adverse drug events, compare unique cases for implementing pharmacist-provided medication discharge teaching, and also identify outcomes associated with the evaluations of pediatric medication discharge counseling. We will first begin with a little bit of background information, taking a look at some literature that really relates towards transitions of care outcomes as associated with medication discharge teaching. We'll also discuss some factors as to why pediatric patients are at greater likelihood for harm and also greater at increased risk for adverse drug events. We'll discuss our collaborations primarily with Delaware ACCEL and also the Alliance for the Integrated Medication Management. We'll go through the development and implementation of a transitions of care pharmacy service, the achievements that we've made throughout this past 3-year grant cycle, the technology tools that we have used both within our hospital as also by partnering with an outside vendor, and also our next steps within Alfred Dupont Hospital for Children and how we're trying to make an impact across our health system. I first want to take a step back in terms of, the mission and vision at Nemours Children's Health System. At Nemours, we have a program or an initiative called the True North, the Nemours True North. And this really stemmed from a patient card review that we received several years ago that said, "Help me receive exactly the care I need and want, how and when I need and want it." And this really stemmed into how can we become more child and family centric? Already we have many initiatives throughout our organization, but it then cascaded into how can we advance child and family experience? And therefore, within our own Nemours True North values, we have 4 main domains. The first domain is quality and safety, and that is how can we have an error-free environment with 0 defects and perfect care? And of course, that's going to be a long shot, Although we might not hit that 0 defects or error-free, we always want to strive every single day in our workflow and practices for having a 0 defect environment. Our second tier is delivery. How can we have no delays associated with the care that we provide? Our third is cost. How do we achieve greatest value at lowest cost? And lastly, our people. How can we focus in on the associates that we're working with side by side and having 100% engagement? And really, this project, this work that we've been doing to advance pediatric discharge teaching has hit all 4 domains: quality and safety in terms of how do we advance our clinical pharmacist interventions, thus being able to intercede for the patient and intercept various types of adverse outcomes that may affect the patient down the road. How do we improve our delivery? Basically, we can look at the times in which it takes for our pharmacists to prepare and review a medication discharge list and then fully execute discharge counseling. Cost. Being able to identify how we can mitigate harm also ties into how we can save money for our organization, but most importantly, for our patient. And lastly, 100% engagement. As many folks who are pharmacists and pharmacy learners in the room, we recognize that as PharmDs, there's a lot of hours that are being spent, a lot of training that's been spent towards becoming a pharmacist. And we really have a great position to be not only the pharmacy operations true dispensing, but also be at bedside and be able to make an impact for our patients as they go through the transitions of care process. I want to highlight real quick, within the literature, we all know transitions of care can be a very, very complex environment for any patient, adult or pediatrics. And for those who may not be in the clinical realm, what this relates to is the transitions of care in different aspects when a patient is entering into the hospital. So that is when a patient is being admitted, when they navigate from one level of service to the other, perhaps they're going from a general medicine, general pediatrics environment to now an ICU or vice versa, and a very severe ICU acute care area to now more of a general step-down area. And then there's the last phase where they're then discharged, and that's also a very tricky area. So you can see transitions of care is really a multi-step process, and it involves many key stakeholders: physicians, nurses, pharmacists, social workers, respiratory, et cetera. I'm sure I'm missing some other folks. And so since it does involve multiple steps and multiple associates, the process is so complex with many risk factors for medication errors. In fact, in the literature, in a number of studies, there's a range about 15 to 40% of patients will have at least one discrepancy in their medication discharge list at discharge. And it really highlights the importance of having a very comprehensive approach in terms of how we do discharges within any organization. And that's really impactful because almost 1 out of 5 patients then result into a readmission within 30 days. And so being able to recognize this, we see that there are so many barriers to medication safety, and it's really multifold. So that's transitions of care. Let's add on another aspect, the clinical aspect of pediatric patients. Pediatric patients are not just, smaller adult children. Pediatric patients are unique from a pharmacokinetic perspective. They're unique in terms of how we administer and prepare medications for them. And so an organization, ISMP, the Institute for Safe Medication Practices, has identified that almost as many as 1 in 10 hospitalized children are impacted by medication error, and approximately up to 35% of these errors are serious or life-threatening. That is, they reach the patient, they cause harm, and in some cases cause permanent damage. And so when we compare this data with the adult world, pediatric patients are 3 times more likely than adults to experience harm from medication errors and adverse drug events. And why is it that pediatric patients are at an increased risk for adverse drug events? Well, it's multifactorial. The first is the multiple complex dosing regimens. With pediatric patients, a lot of the doses are weight-based, and therefore there's additional calculations that need to be made. In addition, there's less evidence in the medical literature. In some of the pharmacologic trials, there's a lot of adult subjects, but in some of the pediatric information, we're oftentimes limited, and we need to extrapolate from our adult colleagues. Our third is the lack of pharmaceutical formulations. I mentioned earlier that with pediatric patients, sometimes they have some unique aspects in terms of how they obtain or how they actually take a medication. Some pediatric patients cannot swallow, tablets, and therefore they need to be extemporaneously compounded. As a result of having this lack of pharmaceutical formulations, it then needs to be compounded. There's sometimes concerns with stability data. There's some issues sometimes with, is that recipe, good for 7 days or 10 days? Our fourth issue is psychosocial. With pediatric patients, a child may come from a family where they're in a divorced family and they're split. And maybe mom takes care of the child Monday through Friday, but dad takes care of the child Saturday and Sunday, or vice versa. And as a result, some of the communication of the medication information may be missed, especially when there's multiple key players in the room. And then lastly, the last example that I have here on the slide is that patients sometimes, depending on the age, may have the inability to express concerns. For the adult patient, sometimes they can articulate how they're feeling when they've experienced some sort of side effect. But for kids, it's mostly crying. Maybe you have a tug of the ear here or there, and you can see some other physiologic changes. But other than that, they can't really verbally express their concerns. And so with all these concerns in mind, transitions of care, the concepts of pediatric pharmacokinetics, and some of the lack of pharmaceutical formulations, we decided at Nemours partner with 2 really strong institutions, the Alliance for Integrated Medication Management and also the Delaware ACCEL team. Nemours, I just mentioned earlier, we're the Alfred Dupont Hospital for Children, the pediatric hospital here in Delaware. And so we said, we're just the one pediatric hospital here in Delaware. Who else can we partner with? And so we were fortunate enough to partner with AIM, the Alliance for Integrated Medication Management, where it is a network of like-minded institutions trying to advance medication teaching, discharges, and other aspects of transitions of care. And also partnering with Delaware ACCEL, particularly for our biostatistical support and also a support for our research design. And so with that being said, I want to highlight that really our work of the past 3 years has a strong aim in terms of advancing pediatric discharges, and that's to recognize the unique challenges of treating children and increasing the chances of medication errors happening during hospital discharges. Therefore, we aim to incorporate additional medication education and follow-up primarily provided by our pharmacists, and to improve safety and potentially decrease medication-related readmission. So again, as I mentioned earlier, we started in 2016 with a Cardinal Health grant. The original grant writers were myself, Danielle Sarek, a nurse scientist, Chris Calamaro, also a nurse scientist, and then Mary Pat Winterhalter, a manager for our nurse patient navigation team. And really, over the past 3 years, it has evolved into such a fantastic multidisciplinary team. Our first effort. Our first year focused primarily with our nurse navigators, the partnership with Dr. Hilmas, our clinical coordinator, and VWin, our pharmacy resident and unit-based pharmacist. And then it expanded towards a second year of identifying who else could benefit from this work. And so we decided to partner with our case management team, primarily Don DeFilippis and also Justin Simpkins, our pharmacy resident, in looking at how can we advance antimicrobial education, because we see in the literature there's oftentimes early discontinuation of antimicrobials or improper use of antibiotics in the areas outside of the hospital setting. And then lastly, we decided to focus more where we are now in year 3 with our case management team, partnering with Lindsay Fitzpatrick, our current pharmacy resident, and our clinical pharmacy specialist, in looking at what are some of our key factors from big data analysis, looking at Nemours specific length of stay, disease-related groups, number of medications, and number of high alert medications, and then determining how can we create a targeted approach into figuring out how can we best identify which patients are at greatest risk for adverse drug events and early readmission into the Nemours Children's Health System. So with that being said, I'm going to turn the program over to Dr. Hilmas, as she's going to share with us some of the implementation and our program objectives.
Thank you so much, Mike. So before I go into the program objectives, I'm just curious, in this group, how many of you, by a show of hands, are involved with discharge counseling or in that process? Okay. All right. So then this will be really interesting. I think for those that are involved with discharge counseling, there could be some really nice items that you pick out of our talk. But those that are not involved, I think there's certain concepts and approaches that we took to this project that may apply to whatever research initiative that you're trying to do. So to talk about the program objectives, so again, we wanted to focus on initiatives that improve the transition of care for our hospitalized pediatric patients. And what does that include? So really trying to find a need that we need to do a better job with our education for patients and families. We also had the theory that having a pharmacist involved at that process may allow us to identify problems before discharge and then make it a little bit safer during the transitions. We also felt that having a multidisciplinary collaboration, so going out beyond pharmacy, really can help us to identify those patients that would benefit the most. And then each year, because this is a 3-year grant, we decided we were going to do a review and say, how can we keep building on the gains that we've had? So as far as the nitty-gritty of what we implemented, we started out with developing that collaborative relationship with nursing. Absolutely critical, and I do encourage all of you, whatever project you're doing, try to involve as many different disciplines as you can. It gives such a great perspective to the work that you're doing. So we worked very closely with our nursing colleagues. They helped us to identify patients that they felt would benefit the most from counseling, because I'm sure that this institution is like ours, several patients being discharged on any given day. How do you pick which one to target? So once their patient was identified, the pharmacist would do a pharmacy review of the medications and see if there's any problems, any issues that may come up during that discharge process. And then we would go and talk to the prescriber and say, hey, I noticed this and this and this. What do you think? Is that fine? Just a great conversation before that patient heads out. Then once all of the information is solidified, we would go in and talk to the patient and the family and go provide the discharge counseling, going over each medication. And then we would document the interaction and any interventions that we made during this phase of care in our medical record. And then we had an aspect where a pharmacist would make a phone call after discharge just to make sure, did they get their medications? Are there any problems? So that's the crux of the program that we implemented. Some important milestones for our initiative is really looking at ways to make it efficient for the pharmacist. So one of the things we identified is that why don't we just put all the documentation right within EPIC, which is our medical record, so that they don't have to go to different locations to say, okay, put this here, I put this there. So we really worked hard, and this is something you'd want to start on day one because it takes a while to build some epic tools, which I'll go into a lot more detail in a little bit. We also decided to help to have a resident lead for each year of the pilot program. And this was such a win-win for us. So the residency program, this is usually folks that have graduated from pharmacy school and then want to do 1 year of postgraduate education. They are required to do residency, they're required to do residency research. So it made a nice connection to say, hey, okay, you have to do research. We have this grant. Let's work together and see if we can keep building on that. So that was an important piece that I think would help with any type of program that you're trying to implement. We also wanted to have some standardization. It's easy to say, okay, you do what you want to do, you do what you want to do, but then the outcomes are very hard to measure. So we wanted to have a standardized approach. I'll go into a lot more details with that, but we created a training manual so that, it doesn't matter which pharmacist is doing this counseling, they're going to be doing the same steps. So there's consistency. And then one of the most exciting pieces is developing a data dashboard to catalog our program outcomes, which helped us for two things. Quickly identifying what the impact was for the pharmacist and what we call cost avoidance, so things that if we hadn't gotten involved may have caused some cost, and then looking at our readmission rate to see if are we impacting patients, educating them so they don't come back. So I wanted to transition and talk a little bit about the tools that we developed. The first tool, this is a screenshot out of our Epic. And at the top is that patient list. So I talked about we have a number of patients that are being discharged in any day. So how do you identify them quickly? So we created a patient list. In the beginning, we identified them based on a consult. Later on, we started to look at different ways to identify them. But it starts out with who are the ones that are being discharged. The next thing is the tools for patient assessment. So if you have a number of patients that you're assessing and trying to determine whether to target them for discharge counseling, it's very difficult to just go through that list and click each patient, pull up their record, do a review. So what we did is a snapshot, which made it a lot easier. We have a number of patients that go home on no medication, so I'm not going to be spending a lot of time reviewing them. So this snapshot is very helpful. It allows us to see if the medical team has already decided what medications this patient is going to go home on, which is pulled up right, get my cursor, right in this area. Ask your doctor about these medications. So these are the things that they might be going home on. We have a section here for the pharmacist to communicate with each other. Hey, call mom. Mom is the right person. This is the best time to call her. We have a navigator, and this is our jump into the medication navigator, which I'll show you in a lot more details, but also what medications they're on. So instead of having to open up the whole chart, quickly, just one click on their name, I can see if, yes, this is someone on several meds, I would want to target them. Once you hit that button that says jump to the navigator, this is the screen that opens up, and it's wonderful in that it's all within Epic. So a couple of things I wanted to bring your attention to. On this side where it says discrete values for documentation, this is where we put in all the details of how much time it took, what was our success, how much were we successful in having a discharge or not. On this side, on this other side is a summary for clinicians. So I can pull in the information about that sticky note. And also I can see if there was other interventions that a previous pharmacist may have done on this patient that may help me to come up with additional interventions upon discharge. And I can quickly see that someone already do this discharge counseling. If they did, then there's information over here to show that it's been done. Now it's time to do, perchance, the telephone encounter. So as far as the information that we decided, there's so much information you can collect, but what we decided to collect to look at the value of this program was the number of discharge medications that the patient was going home on, how many are new to the patient, so really they've never been on it, there's a great opportunity for error, need for education, anything that's been changed, anything that's been stopped, some details about the caregiver, and then what type of interaction, because we, as I mentioned before, we would do the discharge counseling and then we would do a number of phone calls afterwards. If I were to do a discharge counseling, I'd hit that button and another screen would open up, which is right here, and tells me how many attempts did it take. That's important information for pharmacy. If it's taking us 4 or 5 attempts to keep getting, or we can never get to the patient, that gives us valuable data. We might need to look at a different patient population. Who did we talk to? How much time it took to do the different phases? Before you even go in, you're reviewing the list. That takes time, talking to the family. Oftentimes there's something you have to follow up with after you do your discharge counseling. How much time does that take? So this is really good in allowing us to assess how much of a burden or how much time it's taking for us to do this work. We also wanted to document the interventions that the pharmacists were doing. And one of the key pieces, depending on what type of research you're doing, make sure that your documentation codes are unique. So what we did is we created something called the CH Grant Medication Counseling Intervention Code, so that if I'm looking at thousands and thousands of interventions, I can quickly pull out those interventions that were related to this initiative. And so the analysis is much easier. So I mentioned we had our residents involved in our pilots. Every year of the grant, we had a resident involved, and it's been tremendous how they can build on work. So I wanted to go into a little bit more detail about that. In year 1 was our development time. So really trying to come up with building those relationships, building those EPIC tools, providing education to the providers that, hey, this is a service that we're providing. We did a pilot with the resident. In our residency program, we have dedicated research time, like 6 weeks or so. So we said, okay, during that time, try to reach as many patients as you can with discharge counseling. Let's see if this works. What's working, what's not working. One of the things we identified is that we were having trouble transitioning it from the resident to our regular staff. That's important information. So in the second year, we said, okay, maybe if we decrease the time burden that it takes. So we focused on an antimicrobial stewardship type of initiative. If you get started on a new antimicrobial, we would target you. Now you're not dealing with 6, 7 medications upon discharge, just one. Maybe it would be a little bit quicker. But we added an additional piece of a quiz just to see if they understood antimicrobial stewardship concepts. So I alluded to this before, so we really wanted to standardize our approach. So we created this training manual for our pharmacists that goes over each step. What do you do in the beginning? Where do you go in EPIC? Where do you document this? And what's been happening is each year as we're fine-tuning our program, I can always refer back to this, update it. Even this week, we came up with some suggestions on how to make things even better. Now I have a resource that if someone new comes into our institution, they'll know how to do this process. This is one of the most exciting pieces. So all that hard work into building EPIC up, having us put our data within EPIC, now led us to being able to send that information over to a large data warehouse, and then from there, pulling that data back out quickly in a ClickSense dashboard. So this is kind of our data dashboard. I have to provide quarterly reports to our Cardinal Grant administrators. This makes my life so much easier. I'm able to quickly see how many we're reaching. You notice there's big bumps in January, February. That's when our residents are on their research month. Then we seem to falter and then move back up. So it's great information that we can quickly see, and I think it would be applicable to whatever type of project that you're working on. So as far as our refinement, year 1 was that strong collaboration between pharmacy and patient navigation services, and we started to target many patients on many medications. It took a long time, so we learned from that. Then we decided, okay, let's not do so much of a focus on the patient navigation connection, but let's try to go to a rapid turnover unit, less meds that those patients are on. So we focused on antimicrobials. But this past year, we're really working on a sustainable program. So we're seeing it wasn't that sustainable in year 1 and 2 beyond the residents' contribution. But now what we're doing is we're trying to target the patients based on readmission factors, and we're looking at ways that we could have a dedicated workforce to be able to do this initiative. So some of the information since June of 2017, now our program was before June, but everything was documented using ACCEL. So it takes a while to compile that, but the data dashboard is just so easy. I decided to share what we had since it was up and running. So we were able to reach 132 patients. Recently, I was asked by my director to quantify what happened in 2018. So we've always done anticoagulation discharge counseling per the Patient Joint Commission patient safety goal. So in 2018, we had about 25 patients that we did that discharge counseling, but then we had almost 75 patients through this grant. So we tripled the number of patients that were able to provide education. So this is fantastic. We're definitely moving in the right direction. The number of medications we've counseled on is staggering. So many medications. And these patients are fairly complicated, up to 7 medications, on average, I apologize, 7 medications per patient. We had more interventions than meds, so that's a good sign. We're definitely getting involved. And we have a cost avoidance number that's associated with each intervention based on literature. And it looks like around almost $80,000 of cost avoidance that we saw. The other thing that's really exciting is that at our institution, we have like a readmission rate on average of about 10%. But when I did a in-depth chart audit, and this is more recent, but an in-depth chart audit for the patients that we reached, and looking what was the reason that they got readmitted, it ranged anywhere from 0 to 3% of our patients were readmitted. Now, of course, they do get readmitted for elective and other things, but due to their index case, we saw a pretty low number. But again, this is very preliminary. I think it'll take a longer time frame to really show an impact. So some of the example interventions that we're doing for the pharmacists in the room, probably no surprise, but issues with that discharge prescription, that dose is too low, making sure it gets corrected and resent so there's no errors there. A lot of times nurses may not be 100% thorough with the education of this medication has to be given at this exact time and this medication at this exact time. So we took that on as our initiative, so making sure there's no drug-drug interactions. There was one time, actually, this is something that I had done. I was counseling on albuterol nebs, and Dad turns and says, I don't have a neb machine. How am I going to do this? So I was able to contact social worker. Again, the value of having that multidisciplinary team. They had the neb machine in their office, came around, and they're good to go. We had another pharmacist that provided information about emergency hydrocortisone dosing, how to prepare that. A very appreciative family for doing that additional education. I've had situations where the wrong concentration is being given to the family when the physicians thought a different concentration. This is, twofold error. So we were able to catch that. We had other situations where in follow-up phone calls, we're finding family members that are not understanding how to give medications, giving quadruple the dose that they needed to get. I don't know when that would have been caught if we didn't make that phone call. So a very important piece. We also help those that aren't being discharged to home. They might be discharged to a skilled nursing facility, and being able to help them understand. They're very appreciative of us being able to give a list of medications, and then they're quickly able to identify if there's something off. Doses being too high. And then there are situations where family just didn't quite understand when they're supposed to stop therapy. So after that discussion, we're able to go back to the prescribers, say, okay, what was your plan? And then be able to give them a little better education as to what the appropriate plan would be. So as far as sustainability, we talked about our PDSA cycles. So we looked at very different referral sources. Are we going to look at patient navigation consults? Are we going to look at high rapid turnover units? Or are we going to start looking at those patients that are under case management? Just so many different things we could look at. We looked at the number of discharge meds that the patient was on. Do we go for those that are more complex or those on less meds? And then the way to determine that is how much time is it taking for us in pharmacy? So what's the time commitment for the different approaches? So each year we're able to look at that and build on it. Some of the scale and spread, one of the exciting things is our executive leadership was very interested. It aligned beautifully, as Mike mentioned, with our strategic objectives, and they have a strong interest in preventing readmissions for various reasons. So this made sense that, hey, additional education before you go home will be beneficial. They asked us to actually partner with our value-based services, which is a fairly new department within our hospital, and see if we could synergize together and have our efforts efforts work along with the efforts done with other groups. I would say one of the biggest aha moments was the expansion of our case management department and then building that collaboration. Literally now we have a chart of each clinical specialist and what is the case manager covering their patients. And they work very closely. They round together on a weekly basis, talking about those patients that are going home, because pharmacy has such a great insight. Oh, that's going to take prior auth. That's going to take a while to compound. Did you think about A, B, or C? So it's wonderful to see them aligning together with the case managers, attending the rounds, and really now we have pharmacy at the table for all the readmission work that's being done at our hospital. As far as transformation, one of the exciting things is we had a unit-based pharmacist position model, which is now transitioned to clinical specialists. So they now have a little bit more dedicated time in the afternoons to do this. So we're able to sustain. We also now have the ability to provide our discharge education in 10 different languages. So far we've had Haitian Creole, Mandarin Chinese, a lot of Spanish. So it's nice to be able to give them the information the way that they need it. And then now we've worked on trying to integrate these plans that we come up with right with Epic. So it pulls the medications from Epic, builds the plan. So we have decreased time. So you can see here, before the implementation of that integration, it took about 54 minutes. After we implemented, after only about 12 weeks, we have gained 30 minutes. So it decreased our prep time substantially on average for each patient. So very exciting. This is the plan that we provide. This is the MedAction Plan Pro, which is integrated within our Epic. So what it does is it pulls the discharge prescriptions that the provider has placed into this schedule that you can set the times, you can put in information about specific instructions that you want. Here we have Prograph, maybe you hold the medication when you come to clinic. So a lot of great information, and it really, I would say it's kind of the center point to us doing our education versus coming in with 100 leaflets about each medication. We have a plan that really lets them, when they go home, they know exactly what they need to be doing. And one of the things I have up is the different languages that's available in right now. Okay, with that, I'm going to transition back to Mike.
Well, thank you so much, Elora, for sharing the great work that we've been doing for the past 3 years here at AI. Again, just to recap, the 3 main areas that we've made initiatives are, the first year was focused on partnering with our nurse navigators for medically complex children. The second is really focusing with case managers and also looking at how can we improve antimicrobial education. And then where we are currently in year 3, we are looking at big data, identifying what are some of the patterns and trends within our own Nemours data set. And our hope is to see how can we create a targeted approach. Really, this has been a fantastic 3-year journey. And for this reason, I'm actually not surprised. Nemours medication discharge counseling, our pilot, has been featured in a number of different avenues. The first image that you see to the top left of the screen is at the Children's Hospital Association. And that in the picture is our former president of Alfred Dupont Hospital for Children, myself, our colleagues from Nemours Children's Hospital, and also Danielle Sarek, our nurse scientist, where we were able to share our work with many pediatric healthcare providers, leaders from across the country, and just share our thoughts and get feedback from them. It helped us to also rejuvenate how can we tweak different aspects of our program. Towards the bottom left part of the screen, it was a presentation that we provided at the American Society of Health System Pharmacists mid-year clinical meeting, and partnering with Wilkes University's School of Pharmacy in providing an update on what we're doing from a transitions of care project, and also how Wilkes University is partnering with their students in providing similar types of workflows. And then the image to the right is a cohort of members of the Alliance for Integrated Medication Management. And the lady in the brown actually is the executive director, the lady who's been helping us connect the dots with other like-minded institutions trying to advance medication, discharge teaching, and other aspects of transitions of care. We were fortunate enough to have one of our project years published in the Journal of Pediatric Pharmacology and Therapeutics. And this was also a great win for our pharmacy residents to really get involved in not just presenting at a national conference, but also to have their work published and featured in a national journal. And this here highlighted the development of an interprofessional pharmacist nurse navigation pediatric discharge program. We're currently have submitted one of our manuscripts over to the Journal of Pediatric Quality and Safety, and this is more focused on antimicrobial education. And also, this is going to tie in nicely based on some of the concerns that we're seeing across the country from an antimicrobial stewardship perspective, an antibiotic resistance perspective, and being able to have pharmacists share their knowledge with patients and family members upon discharge is really crucial. In this data, you see here that about 50 patients were counseled, and in terms of education, before any type of education was provided, the CDC quiz that was administered to them was on average about 69%. However, after pharmacist intervention and pharmacist impact, about 100% of the scores, the scores then had an average of 100% in terms of accuracy. So being able to tie in these metrics, I think, will really make an impact towards not just pharmacy workflow, but also towards outpatient pediatric outcomes. And then where we are now is their data mining, primarily with large data of Nemours data sets. And this is just a copy of our poster that we had shared at the ASHP mid-year clinical meeting this past December, where we are developing a scoring system to identify pediatric patients at a great risk for a 30-day readmission. And so some folks might use different types of predictive analyses or different scores that may be used, especially in the adult setting, such as LACE. Perhaps it's looking at length of stay, acuity, comorbidities, whether or not they were admitted through the ED. Well, what we decided to do was take a somewhat similar approach and look at, within our Nemours specific data, in terms of the hospital admission type, were they elective, were they emergent? What were some of the team factors associated with it? Were they primarily on the hemonc service or diagnostic referral service? We're looking at total number of medications at discharge, length of stay in hours, and also different types of disease-related groups, and being able to identify those areas or those variables that have a higher likelihood in terms of statistical association with a 30-day readmission is how we're going to target our approach in terms of which patient do we see first versus later on in the day. And so where we are right now, Lindsay Fitzpatrick, our current pharmacy resident, she'll be presenting at the Eastern States Conference. It's a regional conference for pharmacy residents where they can share their year-long work. And so Lindsay will be presenting a nice Pearl presentation later on in May. So this has been a great journey so far. As I mentioned, it's been 3 years of partnering with internal departments, partnering with outside agencies like AIM and Delaware ACCEL. So our next steps as we continue to advance pediatric medication outcomes is to continue the refinement of the MedAction Plan Pro. It's the software that Elora was sharing with us a couple slides ago. And our hope is to expand this to other disciplines. So it's working really well within our clinical pharmacist specialists and different teams. We want to expand this towards other disciplines. In addition, already we have a nice set of languages. There's about 10 languages that are already live, up and running. Our next step is to see how can we get additional languages added towards our software. This way, we can advance our work, especially for those patients who do not speak English as a first language. And also customize our commonly used meds. In the pediatric world, there's oftentimes where we have to make a unique concentration, or there's a unique formulation or a unique way in how we administer an agent. And being able to customize our own Nemours commonly used medications with defaulted text is going to streamline the process, as well as enhancing our drug library and adding other types of agents that are not readily available. One of the other things that we're highlighting too is that we do have an incentive for our pharmacists to provide transitions of care services, and that's primarily a stem off of our True North goals. If you recall, when I shared in the first couple of slides, our True North is based on quality and safety, delivery, cost, and people, and this really stems nicely in terms of a performance management goal. And so our pharmacists, as part of their yearly evaluation, will be assessed on discharge counseling. In addition, we have planned enhancement of a discharge patient list, again, tying back into our 2018 Nemours data to figure out how can we facilitate the identification of patients at greatest risk for readmission. And lastly, we've partnered very strongly with different nurses, nurse navigators, case managers, et cetera. But our next step is how do we further this work with other physician colleagues? And so already there's some physicians on board with transitions of care services, and now being able to link up in a more formalized manner will help expand this across our institution. So when we think about it, is there value, right? Is there value in having a pharmacist do this discharge counseling? The answer, in my opinion, is yes. It is a cost-effective strategy to integrate a pharmacist, especially with discharge education process, from the perspective of improving safety and providing high-quality medication education, which ultimately will make an impact in preventing patient readmissions. So therefore, as we look back over the past 3 years, nursing has been very supportive of this collaboration. Bedside nurses, nurse navigators, case managers. What we recommend, it really does take a whole team, regardless of the initiative that we're doing. Also, having grant support, having some cost associated, dedicated for pharmacists involved in discharge teaching was really important for us to exponentially grow and propel our discharge counseling efforts. And as we saw throughout this 3 years phase, we took different types of approaches. And what that did, it created a PDCA approach, a plan, do, check, act cycle, where we can refine it year after year, and being able to take what is it that was working well and continue that, and what is not working well and tweaking that. And through refinement each year, we're able to make a more sustainable model that we can use moving forward. And we are just, as a team, so excited to see value of a mature transitions of care program. In my opinion, you just saw Elora and I speak today for this past 45 minutes or so, but we really would not be where we are if it weren't for Tony Farah from the Alliance for Integrated Medication Management, Amy Hemphill, one of our epidemiologists and data statisticians from the Nemours Continuous Improvement Department, Chan Kong Jiang, also known as Laurel Jiang, for her biostatistical support, also linked with Delaware ACCEL, V. Wynn, Justin Simpkins, Lindsay Fitzpatrick, our current and past pharmacy residents, and also the teams, nurse navigation, case management, and our clinical pharmacist specialists for all their support that they've provided us over these past 3 years. And with that being said, we'd love to answer any questions that you have about our project and how we're really trying to advance our outcomes associated with medication teaching, decrease any type of medication errors, and also prevent any type of 30-day readmission. Yes, a question in the back. Great. For those who are online joining us through phone or through the internet, the question is, have we seen the models that we just presented particular just for pediatrics, or have they been expressed in other avenues, especially in the adult setting? In my opinion, at least in the Children's Hospital Association, there has been some discussion about how can we better employ nurse navigators. And so nurse navigators, and I can't remember if there's a division here at Christiana for nurse navigation, but our nurse navigators are a partnership in terms of dual functionality of assisting with getting materials, equipment, such as the work with our social workers, and also being able to translate that from a clinical bedside nurse perspective. In my opinion, a lot of these strategies that you see here Although that these were applied in the pediatric setting, a lot of these could be most definitely applied towards the adult care setting. So for example, the first year we focused on medically complex children. These were defined as having 3 or more specialty visits after discharge. And we could imagine, especially whether we're at Christiana or at another Delaware institution, a number of our patients will then see a cardiologist, a nephrologist, an endocrine specialist, maybe someone from hemonc, and being able to work with a nurse navigator to tie in all those specialty appointments, to tie in all that equipment that's needed, and to follow up. I think that's a great strategy. And then in terms of the application of our antimicrobial education, I think, of course, it's important in pediatrics, but I think it's just as important, maybe even more important in the adult setting. I mean, if we look at, some of the causes of, antimicrobial stewardship, sometimes there's issues where we're constantly ordering the same type of antibiotic over and over again without looking at some of our own hospital-wide antibiogram. Perhaps it's early discontinuation of an antibiotic, and as a result, people are like, oh, I feel much better after 3 days of taking this antibiotic. I'm going to stop taking the next 4 or 5 days of this regimen. And as a result, now the bug becomes more resistant. So I think that these are very impactful in terms of both the pediatric and the adult care setting, and they could be applied towards multiple avenues or multiple patient settings. Yep.
So,
yes.
Related to the identification of the patients whom you think are at risk or need the service, do you base it on an EPIC algorithm, on the number, on the readmission or something like that? Or is it something that the clinicians will tell you, oh, you really need to, I really want you to take care of this patient?
Sure. And then I can probably give my take on this. I'm sure Elora will have tons of things to add. Where we are currently, we're doing big data analysis, so being able to identify different types of variables within our Nemours-specific data. So I know it's tough to see here on this slide. Again, this was just more kind of a visual, but throughout this year, we looked at length of stay, we looked at certain disease-related groups, we looked at number of medications, and we did see some trends, some associations rather, with certain disease states. So for example, if you were a patient who had some sort of hematologic oncologic condition, you may be at greater risk for readmission compared to other patients. Within our data set, although not statistically significant, we did see a cutoff in terms of the number of medications also playing a role in terms of potential readmissions. And so being able to take into look at our own and more specific factors, that's what's helping us create a targeted approach in terms of, okay, I want to see, baby A versus baby B first, because baby A has been here longer, is on more medications, and has perhaps a hematologic condition and more, whereas baby B has only been here for a day, and maybe they're on 1 or 2 medications that are not high alert. Maybe they're on a vitamin D, and then perhaps some sort of other nutritional supplement. And by being able to take a look at multiple factors, it's going to help us in terms of how do we actually target our patients. Elora, do you want to add?
Yeah. So everything that Mike says is accurate. It's just a work in progress still, so we don't yet have those factors built into a patient list that says, okay, these are the patients you would target. We're working on that. But I would say on a day-to-day basis right now, it's the case managers that have very complicated patients. They're kind of stuck here for whatever reason. They call us. They call the clin specialist and say, hey, I know this kid is going home in 2 or 3 days. Can you start working on it? And I will tell you, there's tremendous value in having that additional time to prepare. Even though we've gained some efficiencies in creating our med list and things like that, just having the case managers have an eye out for it and give us a heads up a few days in advance allows us to be more successful as well. So that's what we're doing at this very second, but in the future, I think we'll be in a better spot to kind of pull in the data and have that determine our decisions.
Yes.
So another part of transition care is kind of when you're entering the hospital system, you guys have a process that looks at the methods of.
You highlighted a very important aspect. For those who are on the phone or online, the question is, do we have a particular process somewhat similar to this for the admission process, since we've done a lot of work with the discharge process? right now, pretty much our pharmacists are involved more in the inpatient type work. I know that Nemours is in the process, or AI is in the process of hiring for an ED pharmacist who will help streamline the admission medication reconciliation process. I don't know, Elora, do you have anything else that?
Yeah, so I think we do have a workflow within our pharmacy staff that when someone's getting admitted, it's a brand new admission, we have the ability, because we have something called One Nemours, so you can see the inpatient and outpatient meds. So a lot of our pharmacists catch errors at that point because they've ordered this, but the med list looks like they're on this other dose. So that work is going on right now. I also feel that we refer to that home medication list as well during discharge. So kind of circling back, oh, did we forget something that they were on before held for the hospitalization needs to be restarted once they're home? It's really nice to be able to see both lists.
Yes, of course. Yeah.
So what is your capacity? How many children can you reach right now for the discharge process every day?
Yeah, go ahead, Elora. Yeah, go please.
Okay, so the question is, how many patients can we reach? What we've done is we created a performance management goal for our clinical specialists. We have 8 of us. We're trying to target at least 4 a month. If you get 4, you get the highest rating. But I will tell you, we went around the room and asked folks how they did in March, because that was our first month. There are certain people that, 2 or 3, other people like 9. It really depends on the service. We have 2 clinicians in the general medicine or general peds section that see a lot more. So it just depends. I would say on any given day, maybe like 1 or 2 that's happening. And I think as we become more efficient and we start to gain more experience, because the clinical specialist model is fairly recent for us, I think we'll be able to catch more. I know here it would be, astronomical, the number that you have to deal with. That's why I think it would be important for you guys to figure out which are those patients that would benefit the most. Any other questions? Yes.
But in the beginning, you mentioned the nationwide statistics, the error or the percentage. How about Nemours? Before your program implemented, what's the rate or error of discharge issues that you see locally?
Are you talking about readmission rates or
medication related?
I give the readmission, I can do the medications.
Okay. Yeah, I mean, for the readmission, we do have now a data dashboard that allows us to look at the impact. On average, we had like a 10% readmission, which is lower than what Mike had mentioned for the national numbers. And then for our group, when we're looking at readmission for the index cause, our rate is down to 0 to 3%, but over a short period of time. So I'm not ready to, have a party, but I think it's something that we're looking at. As far as the interventions, that's a tough one. I don't know if you have some insight on that, but we weren't doing this work before, so we're not really sure what we missed, unless I guess it comes out through incident reports, maybe.
Yeah.
Okay.
The thing about voluntary event reporting is actually just that, they're voluntary event reports. And so as a result, some institutions, they see, hospital A has, 500 event reports associated with, maybe discharge teaching. Maybe hospital B has 50 voluntary event reports associated with hospital discharge. And so it's not always a good idea to kind of compare it because of the very nature of voluntary, especially with discharges, right? Because after a patient has been discharged, sometimes things can also oftentimes be missed. And so by missing it and not recognizing that it is indeed a medication error or an event, it doesn't actually get captured. It's kind of like for those who are in maybe, the bench sciences, maybe if you're doing, phase 4 post-marketing data, right? Maybe it's after medication's been approved, well, you surely have your, clinical trial information for safety outcomes because that's a controlled environment. But the moment they leave your institution, those things aren't always captured. And so when you saw the first couple of slides, and I could probably go back up into the background slide, we put a range here because of the 15 to 40%. So depending on, we put 15 to 40% because depending on the source you go to, it can really vary, and it also depends on the reporting system, reporting culture, and then other aspects of patient safety culture. Thank you all so much. Appreciate it.